Supportive care for hantavirus infection is built upon a foundation of early recognition, prompt intensive care unit admission, continuous close monitoring, and aggressive hemodynamic and respiratory management aimed at maintaining oxygenation and circulatory stability. This supportive approach is the cornerstone of treatment because no approved antiviral therapy exists for most forms of the disease. The one partial exception involves ribavirin, for which limited evidence exists in select cases of hemorrhagic fever with renal syndrome, though this evidence does not extend to hantavirus cardiopulmonary syndrome, where ribavirin confers no established benefit. Initial management is guided by two overriding principles: cautious, restrictive fluid administration to avoid precipitating or worsening pulmonary edema, and aggressive organ support through inotropic agents, mechanical ventilation, and, in the most severe cases, extracorporeal membrane oxygenation, known as ECMO. All patients with suspected or confirmed hantavirus infection should be admitted to an intensive care unit without delay. This recommendation reflects the unpredictably rapid clinical deterioration that characterizes the disease, particularly the cardiopulmonary compromise that can develop within hours in hantavirus cardiopulmonary syndrome. Fluid management must be judicious and restrictive. Rather than pursuing large-volume fluid resuscitation, the therapeutic target is a pulmonary artery wedge pressure in the range of 8 to 12 millimeters of mercury, a strategy designed to maintain adequate cardiac preload without driving further accumulation of fluid in the lung interstitium. When hypertension persists despite appropriate fluid management, inotropic support, with dobutamine as the prototypical agent, is the preferred intervention. Supplemental oxygen should be initiated early and titrated to maintain adequate oxygenation. Progression to intubation and mechanical ventilation is frequently required as respiratory failure evolves. Non-invasive ventilation is generally not advised in this setting, given the risk of rapid and unpredictable decompensation that may leave insufficient time for the safe transition to invasive airway management. In patients with refractory hypoxemia and hemodynamic compromise that persists despite maximal conventional supportive care, ECMO should be initiated early. Evidence indicates that earlier deployment of ECMO is associated with improved survival outcomes, and accordingly, the threshold for considering it should be low in patients showing signs of clinical deterioration. Continuous hemodynamic monitoring is essential throughout the acute phase, incorporating arterial line placement, central venous access, and a pulmonary artery catheter where available. Any patient with high clinical suspicion for hantavirus infection or early signs of deterioration should be transferred promptly to a center with ECMO. This concludes Hantavirus.